and we're a division of Merck Chemical Company. We're based in Darmstadt, Germany, is the corporate headquarters. Merck Millipore is a huge organization like UNICEF. Believe it or not, we're in 118 countries around the world. So we service a lot of different countries. Millipore bought guava in 2009.
Guava.
Yeah.
Oh, all right. I know about guava.
Good. I was in the original group that developed the Guava Auto CD4. Howdy. So we've been in sub-Saharan Africa and in the Caribbean and in Southeast Asia basically since 2005, marketing in the CD4 market. And what you're about to see today is the newest product. It's still in development. It's the Muse. I just came back.
How far are you?
I just came back from a clinical trial
All right.
in the University of Yaoundé in Cameroon. So we're pretty far along. And I'll show you some examples later in the presentation where we're strong. We're very strong with pediatric patients, and we're very, very strong with cytopenias. And so if you have patients in those two categories, that's where our strengths lie. So this is the Muse, and essentially we have three extraordinary advantages. Our counting technology is absolutely among the best available. We're strong on pediatric applications. Merck as a corporate has a commitment to pediatric patients worldwide, and it's one of our corporate goals, and it's stated there. So we share that also with UNICEF. And then we have environmental advantages over the competition also. It's changed since we launched the guavas in the old days. When you go into launch in these countries now, I have to get individual licenses in each republic that I go into, and often there's environmental concerns that we have to meet, and so we've really worked hard to address all those concerns. So essentially, the sample is drawn from a capillary. There's two pre-dilute steps. There's two 15-minute incubation, one for the reagent and the other one for the lyse. This is down from a 45-minute incubation on the Guava Auto CD4, so it's an improvement. Big advantage is the sample size is only 10 microliters. It's the lowest in the industry. So you're dealing with a very, very tiny sample. I have not completed it yet, but we will be doing a finger stick study so that finger and heel sticks will be allowed. So I wanted to let you know that that's in the works. It's budgeted, I just haven't gotten to it yet. Essentially, once the sample is loaded, it'll pull up to 10 microliters of volume. We measure the volume. We also measure the count. We do the count as the cells align themselves in the capillary one at a time, and they go through the laser. The capillary has a huge advantage as a counting technology when you have very tiny amounts of sample, like is a goal with diagnostic products. And it also has an advantage in counting at very low levels of cells, like a cytopenia that you would see with somebody that's almost tertiary, as what I saw in Cameroon just a couple of weeks ago. Basically, we have two colors of light scatter, and we have a proprietary reagent that does CD4 and CD4 percentage on every patient. So you don't have to separate out your pediatric patients from your adult populations. You can run mothers and daughters together. There's no problem. You know, it's essentially a flow cytometer. The dyes are excited by the laser light at specific wavelengths, so we get a very, very accurate count. Um, the light signals from each cells are quantified as we count them, and the count is verified. And since you measured the volume and you've counted the cells, the math works. And I can tell you versus any technology that if you take and run replicates on this technology versus any flow technology out there, you'll see the tightest CVs of anything available.
So can you just go back to the point you made about being able to run mothers and daughters together? I didn't quite catch that.
Well, one of the things that they liked in Cameroon is often the mother has AIDS and the child has AIDS. And so they would bring them in together for, we did 200 adults and 200 pediatric specimen to make the pediatric claim. And it's a long study, as you can imagine. And oftentimes the child's born with the virus with the mother. So we were able to take specimen from both. And that's part of it. I didn't get to look at anybody's individual names or on the files or anything, but I did happen to glance at whatever I was doing, a female or a male or what age the patient was.
So what you're saying is because you do the percentage and the count, you're able to do that for both mother and baby.
Some of the other technologies are a separate reagent for children.
Yeah.
And that's not the case with us. The also thing is we've achieved another goal, and it's the lowest cost per test of any analyzer out there. I'm on the UN contract at $2 a test, and I can tell you that nobody else will touch that, particularly for a CD4 percentage.
How much do you say, Roy?
$2 US dollars.
For this technology.
Right.
And then for the device, do you have a...
The device will be right about 10,000 US, which is not the lowest cost device, but the lower cost devices are charging you upwards to $6, $7 a test. That's, to me, I'd rather max out the amount of tests I do on it and save there. Big change in the technology, and one of the new patents on it is with a traditional flow cytometer, you actually have what's a culminating lens is very far from the sample. One of the many innovations on the Muse that we put in is that we mounted the lenses right on the capillary itself. And so we are much closer to the cells that we're looking at and counting. And we have a much better resolution than we've ever had in the past. We get a better resolution than some of the most expensive flow cytometers available. How do I go back again?
Slide to the left.
So, believe it or not, this whole technology could fit in a Coke can. It's blown up in size. And you can see the capillary where the cells are aligned. They'll come up, the laser light will hit it, and it scatters with a forward scatter and two-color resolution. So it's a very simple pattern and a very simple way to operate. We've won numerous design awards with this product. It's been out and field tested for 3 years in the research market. We were very cautious about entering into the diagnostics. Okay. And this is our entire flow bench, and you can see it's next to a Coke can. It's very, 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 very similar in size. In flow cytometry, the litmus test of how accurate your counting is and how accurate your cell separation is to take what they call the 8-peak rainbow data test. And in both channels, the Muse pass every test on the 8 things. So it's that if you're a flow person or if you come from flow cytometry, that's the gold standard. So as you can see, we have an optical system that's about the size of the soda can. We get very high resolution of the cells. We can count down to very, very low levels. It's a very, very simple system. It's very simple to maintain, which makes it rugged and makes it very, very portable. The systems that we'll be selling into this market will have a optional battery pack that is also a UPS. So when they're out of the field, they can plug it into the wall. It has a surge protector in it that protects it. When they take it out into the field, they can do tests on the battery. So far, we've tested up to 50 tests a day on the battery, and which is more than ample for most ambulatory care, from what I've been told in Africa so far. I had a long talk with people in Botswana about this. The instrument, and we'll get into it, is touchscreen technology. I tell everybody that if you can operate a laptop and you can pipette, we can train you within an hour. It's very, very, very simple to use. We trained 20 operators at the University of Yaoundé in a day and a half. So.
What was the qualifications of the people you trained?
Well, some of them were med techs, I admit, and usually they were the ones with the lower CVs on pipetting. But we also had pathology med students that were operating it, and they did very well with it also. So
you didn't try to use the normal.
The joke is, it's so simple, even the pathologist can operate it.
Okay. Why did you try it out on nurses? Because they're the ones running most of our clinics.
I'm sure we will before it's over. I basically needed the pediatric and the cytopenic specimens, and so that was my main concern with the list.
To get the specimens you needed.
Yeah.
Okay.
But as I field test it for things like finger sticks, and I go for World Health certification, then at that point I'll probably involve the nurses more.
So if you do a finger stick, will you still need a pattern to get the results?
Yeah. What I'm looking at, I've been talking to people at Griner, and I've been talking to people at some of the other tube manufacturers. But essentially all you do is take the capillary and fill the capillary. And the new capillaries have these little bulbs in it, and they can be predisposed for 10 microliters of blood. So you just take it and pipette it into the tube just like a normal specimen, and from there you go. It's not going to require the butterfly or any of the older technologies that used to be out there. And I hope to do the same thing for heel sticks.
And you don't have a problem with pipetting in terms of viability of cells?
Well, that's the other thing. You can test viability on the muse.
All right. Okay.
We have a viability software, so you just change a button over, and I'll show you in the demo. So counts total lymphocytes, counts T cells, measures the percentage of T cells and lymphocytes, and does a total lymphocyte count. And it's a unique counting, it's different than any of the competition. And run replicates, and you'll be amazed how tight your CVs are. Pediatric claim. The nice thing for pediatrics, again, is 10 microliters of blood. That's a typo there. Yeah.
10 liters.
10 microliters. Okay. The Muse CD4 has combined CD4 percentage results on every patient that you run. So it's not a separate test. The CPT is $2 a test. We've had years of experience working with pediatrics at Guava. We were one of the first to be able to do pediatrics. And I tell my salespeople to demonstrate it at all the children's hospitals, the same with my distributors. Um, this is a pediatric that I did less than 2 weeks ago. Um, the disease wasn't too far along, but you can see we get a very clean separation. The reports are absolutely gorgeous. And with the Muse, if you have anything that works with Windows 7 or 8, any printer that works with them will work on the Muse. So if they want to plug in, there's 4 USB ports, so they can add a keyboard, they could add a mouse, they could add a printer, however they want to do it. About 99% of the samples can be auto-gated. Sometimes I've seen it with the very, very cytopenic ones. The pathologist might want to come in. There's a special screen for administrators that can do manual gating. And the manual gating comes in very, very handy the lower the count. This was a cytopenia that auto-gated. I believe there was very, very few cells there. This one had a 249.2. I had another one. I went down to repeats at 79, which was very, very low. We had one at 10 that repeated at 10 and then went up to 17, but I think that might have been a mixing issue. But for the most part, you can go well under 100 with our system and not ever have to gate. Here's one we did with, had 88.7 positive per microliter.
You can see the concentration is it's not as well defined as the others.
Right. And on the report, it'll always tell if it was auto-gated or if someone did a manual gate. Environmental impact, we produce a lot less weight than some of the competition. A lot of people have gone to these devices with the plastic cassettes, and if you talk to the environmentalist as you fill out the applications to enter the countries with your product, one of the things the environmental hates is plastic, and then the other thing they hate is plastic with infectious disease. So everything that we have can be decontaminated, and there's very, very little waste, and the sample size is small.
When you say it can be decontaminated, how do you do that?
Take the tubes that we pipette the sample into and throw them in a container with 10% bleach.
And you give that, all the people can do that, you mean?
Yeah.
Oh, so you don't have that?
Yeah.
Because you use very little.
Right. This is the older system that we did our comparison against, the Guava. That's Peter Laposo. He's my distributor from SciTech Diagnostics in Kenya. And that's...
So the studies are all done comparing to the gold standard of the Guava?
Correct. That Guava is our... Yes, we will, because that's a requirement for World Health. But initially, to get it out, I wanted to do it with only a CIVD mark to get the product out. I have a huge demand for the product. It's at this point, I'm sitting on orders for almost 300 systems. So I want to finish the product and get it out as soon as possible, and then I'll do World Health, and then I'll do the comparisons to the other technologies. But at this point, all I got financed was enough to get the CE-IVD right away.
Okay. Well, thank you. So you're saying that because you have a double incubation, from from drawing the blood to result is 30 minutes, is that, or is it more?
30 minutes. It's 30 minutes, but you can batch the samples. Like for instance, during the clinical trial, I had batches of 20, up to 20.
Okay.
And so we set up the samples all at once, and we did two 15-minute incubations, and then we were ready to run in batch. And we processed one sample every 3 minutes.
So for the incubation, you can do 10 at a time?
Yes.
Okay.
And how many tests can you run at a time?
I did up to 32 was my largest lot. That took me roughly around 4 hours. So realistically, I've been telling people it's ideal for under 100 a day.
If the clinic is running the whole day, 8 hours?
Yeah. Most of the clinics aren't going that long, though.
No.
And so it'll handle most of the load for the average clinic. And I highly recommend that they buy the accessory pack with the battery. It's only a few $100s. It'll have the ability to do the work of a UPS, but also give them the ability to take the system out and run up to 50 specimens.
Okay. So what's your take home from the new WHO guidelines, since this is both for the count and the percentage? You've spent a lot of money trying to do this do-all thing, where we can do children and adults.
My take home is that if we're successful with this product, I have a pretty good commitment from the company. I have to prove that we'll be successful. This is a business they inherited, and the truth be told, my upper management at Merck, it's all new to them. They've never been in diagnostics. And if I'm successful with this, my plan is to bring out a second generation instrument that'll do more. 40% of the AIDS patients are co-infected with malaria. And we're interested in bringing a system that could possibly do the CD4, a viral load, and a malaria on one system.
Okay.
But I'm not going to get there if I don't sell this. And so that's where I really need the help of UNICEF.
No, I just wanted to, maybe for my colleagues, to say that we really were struggling with how to do a count, CD4, not to count the percentage for children, because most of the machines are not able to do percentages.
There's only 3 vendors that do it.
Yeah, your machine was unique, but for that reason, we've actually pushed hard, because children die young in life, and so WHO now is recommending that we don't need a startup CD4. So a lot of countries are going to be moving to a test and treat approach for children under 5. So that's one thing. So the window for CD4 at initiation for children is really between 5 and 7 for those providers that are still not confident with the count only, to initiate children with a CD4 count rather than a percentage. So there's that. Then the second is that in terms of the marketing, are we going to use CD4 for monitoring? The answer is that that window is also shrinking.
Sure, it's going to go to viral load.
It's going to go to viral load. So it's important for us to think about that. But I'm a pediatrician, and I know that there's always going to be need for CD4.
Yeah, until they wake up on viral load and make it affordable.
Yeah.
And right now, with the PCR methods, I don't see the vendors going in that direction. I'm going to try and bring to market a non-PCR method.
Okay.
That'll bring down the cost and let us push it further into the clinics and into the small hospitals. Because right now it's a shame.
Yeah, so for treatment management, in terms of switching, detecting treatment failure, we're going to be shifting to viral load. For managing patients, if they get opportunistic infections, they're still going to be. So it's just, you need to balance out what your selling will be, because the market is shrinking for treatment monitoring. But for management of patients, if they're not doing well on whatever, it might still be necessary. But this is an excellent effort, because you're able to do a lymphocyte count. It means that then you can move to the other things you're talking about pretty easily.
Yeah, in fact, we're actively looking for collaborators at this point. People that have worked Ideally, what we'd like is a good DNA marker for malaria, and also someone willing to help us develop a non PCR method viral load. These are two active projects. I have John Ambrosiak here with me today, and that's his bailiwick right there. So it's.
So did you put in a bid for our?
I didn't bid this time, and I wrote them an apology, and I told them that I couldn't bid because the product is not out yet, and I was worried about regulatory concerns.
Right.
Ideally, I'll have the CE-IVD mark by the end of the third quarter. We're looking at September. And at that point, I told them that I'd like to be active on the bids after that. What I didn't want to do is go on a bid and then have a customer or a concern of yours that needed something immediately and then not being able to deliver. I don't want to lose my credibility with you. I'd rather wait a year and earn your business slowly than not deliver on time. And I know that you have to make some very difficult decisions sometimes, especially out in the field, and I'm well aware of that. And so I have a concern, just like you do, for the patient. And so we held off.
Okay. No, it's just with the United grant that we have with CHI, this is the process we're taking in defining who our partners are going to be, depending on what you have. And following the bid, we also had a meeting at Copenhagen where all the developers and manufacturers came.
We intended that.
Oh, you came to that?
Yes.
Oh, I don't remember seeing you.
I didn't go. I had Patrick Dow, who's
Okay.
he's a sales manager for Africa. I had him go in my place.
Okay.
He needed to be educated about the business anyway, so it worked out.
Okay, that's good then. You didn't miss out on that discussion then.
No, I was tied up in Cameroon doing this.
I don't know whether there are questions. Rosalie?
Sure.
I have a question about the data piece of this. You said that you can put in a USB and download individual patient records as the specimens are being.
Yes, we could download individual, or we can download in a data summary.
Okay, so you can do a summary so that it can be.
Right, and there's excellent QC on the system. What we have is beads that are covered with Nile red. Nile red is beautiful because it fluoresces in every channel, and so we run the beads in triplicate at the beginning of the run, and we validate the count, and then we validate the fluorescence, and it gives you an acceptance or a rejection based upon that. Usually what I do when I do an installation is I divide the lab in half, and I bring in an ice cream cake and I have a contest, and whoever has the tightest CVs wins.
The reason I'm raising this issue is just thinking about it from a quality assurance point of view from the position of the clinic, or say the health manager of the clinic, that you could actually print out whatever the 30 patients that you saw that day, and you would be able to flag those that had low CD4% or low CD4 counts that required immediate clinical follow-up.
Yes, you have the ability to set your own flags on the system. Okay, the same panic value that the pathologist teaches you to put next to the scope. Usually it's a yellow paper taped to the table. Let's see. You can put those same parameters into the system, and it'll flag automatically like a hematology analyzer.
And there's a proficiency panel that you use as part of the training?
Yes, there is for part of the training, but I don't have the inner lab proficiency yet because it hasn't been out long enough for like the group in Canada that makes proficiency samples, or the group in India that makes it. At this point, I can't even take it to a control manufacturer for a blood control until I have the marks done, and so I'm not there yet. But I made the contacts, and they know I'm coming.
So for the QA, I mean, do you have connectivity for this machine?
Yes. Now, I tell everybody that if you wanted all the machines interconnected, just place it on the bid and we'll set it up that way for you. Okay, and for instance, I have a commitment for 200 systems, and they're all going to be interconnected. They're all going to one Ministry of Health. Yeah. The other thing is from downloading, you can always download to a flash drive and just take it over to your laptop and send it wherever you want.
So that's its own issues or application confidentiality.
Okay.
I have a question about just thinking about the, where you think this machine, what kind of a health facility this device would fit into, in terms of one, the number of steps and the kind of expertise that you think may be needed to operate the device. So if pipetting is required, it may not be something that could be done by a lay health counselor or by a nurse even, or is that something?
We haven't, with the guava, we never had that issue. Our original customer for guava was the U.S. military, and they needed simple flow for multiple things, and we've been very successful selling it to universities. This one model alone, we're approaching 400 instruments worldwide. Many of them are at universities, and the universities love them because every year you get a new wave of grad students that you have to train. And the training's less than an hour, and once they have the pipetting down, it really rocks.
But this is, so just thinking about the field settings in which they're going
to limit the problems with the field center,
yeah,
we have a calibrated pipettes that only do 10 microliters, for instance.
So they won't have to measure it themselves.
They don't have to measure it themselves. And we just came out with a Millipore pipette calibration check kit. So if they have to check the calibration on it, they buy a kit once every 6 months and pipette and then see if they're accurate. So it's very, very simple to use.
And then the other question is just in terms of thinking of the clinic flow. Obviously, for the point of care devices, the aim is to be able to get that result as soon as possible, ideally within a day, so that the clinician makes the decision.
But sometimes they transport specimens also.
Sure.
Okay, and what I saw in Africa, we were up to 18 hours at room temperature.
Okay. Would you see this being used sequentially one at a time, or would you expect that there would be batches done?
I think most people are going to batch.
Okay.
And I see batches of 5 or higher.
5 or higher.
Yeah.
And for one batch to be done, what would be the approximate time from
You have
the start of
yeah,
work?
you have you put the initial reagent in with the blood.
Mm-hmm.
That's 15 minutes. Then you add the lice, and that's 15 minutes, and then you run.
Okay. And in the running times?
3 minutes a sample at the most.
So it would be about...
It's usually around
3
2 minutes a
minutes,
sample, but if it's a cytopenic specimen, it takes a little longer to count.
Okay. So 30 to 45 minutes for a batch of time?
Right. And he's seen it in the field running, he's got examples of viability on there. And you can go into another screen on the same system, and you may have a count of, like this one was 79, but you want to know what percentage is viable. You can run the viability study. We have a separate viability reagent, and it'll tell you how many of them are viable.
That's actually what I'm rolling up there.
Okay. So it's about average. Most of the CD4 machines are about 40 minutes timeline.
I have a comparison chart that I put together for my management, and yeah, everybody's within 10 minutes of each other at the most.
Yeah. Yeah. Well, part of the work that we're doing on the point of care diagnostics is to also think about strategic use and placement. And it's interesting, I've just come back from Mbarara in Uganda. First of all, the providers are very happy that since they brought in the PIMA machine, which is what they are using, they don't have huge fallouts of patients not being initiated because of time to return of results
Sure.
from the lab. But the sad thing is that they said, oh, but we still have to send about 10 specimens per day to the lab because we don't have enough capacity with the PIMA, because it's put in a place where they have more samples that they can deal with. So there's always that we need to think about what the machine can do and how to align that to the throughput of the clinic.
And from your area, they don't have the percentage, so you really can only do adults with the PIMA. Yeah, I've never done a comparison study with the PIMA, but if you talk to Dr. Mabopi Kiao, he has.
Yeah. Okay. Excellent. I don't know whether people have any more. Are we going to be able to see the machine?
Yes.
Okay, you have a question?
Jan, you want to take them through?
Jim, your timelines for
I'm going to complete, I'm going back for a second clinical study. That should take place late June. And so I hope to have everything, my clinical file done by August, and hopefully product release late September.
so you'd be ready to take orders
At
by
late
the
September.
last quarter?
Yeah.
So all you can test so far is in the lab. You haven't done any field assessments.
No, mainly because I needed the patients to make the pediatric claim up to now, and I needed the patients for the cytopenias. And so I went to a spot where they have a lot of children, and it was all concentrated in one area. To do things for like World Health certification, I may go into the field because I want to do the finger stick and get qualified for that. And then the other piece is I want to do a time study on old bloods, and a time study on the batteries. I need to know exactly how many hours the batteries will go.
How heavy is it?
It's 4 kilograms.
Not how any of us. What's entailed in the cost of a test? Why is there?
It's a reagent kit, and the kits come in sizes of 100 kit, or 500 kit, or 1,000 kit, and the price is $2 a test through the UN contract.
But others are like 6 and 7.
Yeah, it's slightly higher, 10 even.
Yeah.
But then the device cost is a little bit higher for this, so you sort of have to be looking at what is the volume that you're doing.
Yeah, but I'm willing to work with anybody. So, it's the main thing is that as far as the reagent, it's the lowest cost. And
We're starting with countries because of these changing guidelines. One of the questions that has come up is, if we buy this machine and then there was better technology, let's say a country switches all to viral load monitoring. The discussion is, would you be able to switch the machine to something, if you were able to develop a viral load machine?
if we develop a viral load machine, I'll definitely have an upgrade program. Okay, same thing if I come out with a malaria or a hepatitis or whatever is also on it. Believe me, the first thing I'm going to do is take care of my base customers, and they'll get a special deal provided they can trade in the old machines. I'm doing that now for Guava users.
Have you thought of leasing also?
I have, here's my problem. In countries where Merck sells direct, then that's probably easier to set up a lease program. But I'm very, very loyal to my local African distributors. Most of the distributors were employees of mine at one time at Guava, and I've set them up in private distribution businesses. And especially in areas where it's very, very rural, and servicing the instruments is an important issue. And these guys have gone out of the way to take good care of my base over the years. I have a very loyal base. And so Sometimes I let them bundle the cost of the service contract into the reagents, and you might see a slightly higher price, but the service cost will be taken in. I pay them their commission out of the $2 that I get from the UN.
And I think more and more countries are actually preferring that option of either having long-term extended service warranties or else even bundling the costs of service and maintenance.
Right.
Just because there have been so many challenges with insurance service and maintenance. But do you work with distributors in all the different countries to provide the service and maintenance?
There's some places where Merck is stronger than the distributor. For instance, South Africa, Botswana, and Namibia. Merck has established service there for diagnostics. Pakistan comes to mind. Merck is selling hematology, chemistry, and immunology throughout Pakistan, so they have a stronger service there. Russia, I use distribution. Most of Southeast Asia is distribution. But India, for instance, will be direct once we get the 510K and apply for entrance into India.
And what kind would you have service centers in urban areas, or would you actually be sending technicians out?
Well, for instance, I'm right now with the Caribbean. I haven't introduced the Muse yet, but I still have the older systems. And I have 15 instruments in the Caribbean. And what I've done is I've set up a central service depot, believe it or not, in Boston. And it's a, how do I put it? In the Caribbean, they have Carnival, then they have Christmas, and they have Epiphany. And so all the AIDS centers are closed during that period. So what everybody does is they ship their instrument in, we decontaminate it, we do a complete overhaul of every system, and we send it back. And I've done this the last 3 years, and I've never had to dispatch a service rep. And for instance, I have a large order going into Cameroon, and the distributor there has built a central warehouse in the capital city of Yaoundé, and he has bought 3 Jeeps, and he can get anywhere in the country to pick up the instruments and bring them back, and so he's going to use a depot service like that. It's very, very expensive for some of these distributors to fly somebody, especially if they're in a more remote location. So in South Africa, they have FedEx and they have UPS, just like us. So there'll be a central depot. I think there's going to be one in Cape Town and another one in Joburg. And so they can get into Namibia, they can get into Botswana. It's really, very, very easy for them to do everything by depot, and that reduces the cost of the service. The other thing I have to watch is the cost. And if the dispatching costs more, so those are in area, if you're in a rural hospital and the only way to get there is by Jeep, then I have to charge that person a little bit more than somebody that's in Yaoundé that only has to go a mile or two to the dispatch to where they fix it. So, it's kind of variations there.
But you would be considering fixing the machine rather than swapping it for another one?
Yes, because they're so easy to fix. We have less than 15 inches of tubing on the entire system, and 90% of what goes wrong with the system the customers fix. The rest of it does require a service rep, and in fact, I have 11 African service reps coming to California in August to be trained. I have my service reps coming from Uganda, from Kenya, from Zimbabwe, Zambia, Cameroon, and Ethiopia, and the Ivory Coast.
Well, so here's your instrument. Essentially, you can see it's no bigger than a typical microcentrifuge. A side of it is just a computer that's actually built in. The fluidics and all the controls are right on this side. The instrument requires 2 bottles, one for cleaning fluid, another one exactly the same size for waste, and simply houses right on the instrument, connects right to the back. The flow cell is a sip that sits right on top, and it uses standard Eppendorf tubes. You can see that there's a loader arm, you can take it, and on the screen here, I don't know if you can all see it, but I have a viability assay that's being displayed. So we can distinguish cells from debris based on size. So there's a size index on the y-axis. Let me just turn it a little bit. Does the camera still pick it up? Okay, good. And so we can actually threshold, it's all touch screen. For finer points, you're just moving it around, and you can have a mouse on there to threshold where the cells are versus small debris. And we can see live cells, which are nucleated stained, versus nucleated and dead stained. In this particular sample, they're most alive, like 98% live. So you can get an estimate of apoptosis, which would be in the middle, but you get a very accurate live reading versus your dead reading. All the samples are housed within the same data set sample. Your file is fully transferable. You can store it on the USB stick, which is connected right in front if you wanted it. You can analyze it at your desktop, totally mobile, no problems there. And it's ready to run for every person. There's a little wash. Essentially, it'll ask you for a tube of water every 10 samples, or you can program it for every 5, every 20. So the cleaning solution goes in here. The water would just be in an Eppendorf tube. It'll just simply say, please load a tube of water. You load it up, it pumps it through, and then it's ready to go for the next set of samples. It's a very simple system.
There's sensors built into the bottles to let you know if you need to.
My experience with running bloods is that about every 10th sample, it'll tell you to run a quick clean with water.
Yep, just need to flush out this flow cell. As you run it, you get an instant numerical calculation of what your actual per ml cell number is of viability percentage and a total cell number. If you have a certain volume and you want to know what the total cell number is in that, you just specify that volume, it'll do all the back calculations for you. And when you export it, it's just an Excel spreadsheet, so do with it as you wish. Let's see. That roughly explains that. You can print it, you can look at it, there's sample names. In this particular case, this sample was diluted 100-fold with an initial volume of 10 mils in culture.
There's one data port on the front and 3 in the back.
Yep.
So when you talk about running a batch, what does that look like?
So as you run it, you simply load a tube of sample. Let's exit from here for a sec. That's fine. You would come in and let's go home. Okay. When you start it up, your screen will likely be more customized than this. This is a general open R&D system. In this case, viability is right up top. I select that. I'm going to run an assay, and there are the steps. It's all on-screen instructions. So if I'm going to have a tube, I will mix and set the sample up, and then raise the arm. There it goes for run. It'll prime the system. Of course, right now there's nothing in there, so a little air pumping, no big deal. I'll prime the system. It'll ask me to verify my settings, make sure that I see the cells in the right places. And then after that's done, like right now we can't see anything, but for example, I expect to see my cells in this neighborhood. So I would take my thresholding for debris and place it wherever I believe that is. And there's a little guide to tell you how to see it.
This is all done automatically.
Yep. Once you hit next, your expectation is that the live cells would be in the upper left quadrant, and the dead cells will be in the upper right quadrant, where large debris, or red blood cells, for example, non-nucleated cells, would be below this threshold here. And in this particular system, it is actually very easy to distinguish contaminating red blood cells from any blood sample. Whether you filter it, Vicol it, act lysate, doesn't make any difference whatsoever. And once the settings are done, again, you have a little guide. Just hit next. And it'll tell you, okay, I'm happy, I'm going to start collecting. Just load tubes, collect, next, collect, next, collect.
So you need an individual to constantly be adding
Yes,
to taking out the
that is correct.
putting the new, so you need sort of
You need a person who will
a
do it.
lab tech sitting there, but they
Doesn't have to be a lab tech at all. But A human
warm
body. Yes.
Warm body.
You need a warm body to run it.
Okay.
Which body that is entirely up to you.
Which is the same as any of our competitors. You have to have somebody locally safe.
Exactly. That's roughly it. There are small sensors on the bottles tell you when one is full and one is empty. So even though they're sitting hidden, it gives you an idea when to refill. That's it. Simple as that.
So the reagents get added or increased every sort of up to 32 specimens of them?
Yeah, then they come in 100 test kits. The dating is, right now it's a year from shipment. So there's plenty of dating usually to get to the accounts. We're going to expand that claim in the next year too.
So this machine will be coming with all the packs for individual patients.
It's not unit dose. It'll be a kit with 3 vials in it that'll do up to 100 patients. Well, nobody calls me unless I'm.
And the pipettes will be part of that.
Yeah, we have an accessory kit that has the pipetters, the pipettes, and then you can reorder the pipettes separately. Most of the African distributors, I can't talk about Asia, but Africa for sure, the distributors carry the same tubes and pipette tips that you need.
And are you working on the technology for the finger prick?
Yes.
Because that can be a challenge too.
We're going to do a comparison, as I said. It'll happen within the next 12 months to make the finger stick clean. I want to do heel sticks too. We like to work with the babies.
Well, thank you. As I don't know whether my colleagues have any more questions, but I think this is, you have, okay.
Yeah, I understand about 5% of what you're talking about. So what I'm mainly interested in is, I mean, what the obstacles would be to like practical use in the field. So
Well, you
If
have
it-
2 limitations, okay, in any technology that you choose, okay? If it's a dry train, you can go further out in the field. The second thing is electricity. How strong is the battery and how long the battery lasts.
you think that's what I was curious. You think that's about a day, and it's about enough time to run 50 tests.
Should be enough time to run 50 tests.
And then you have to
So then you recharge.
Yeah, and then you recharge.
Recharge it and do another 50 tomorrow.
Yeah, you just take it back, plug it in the wall. It takes about 10 minutes to recharge from what I'm seeing so far, and it's ready to
10 minutes
go.
to recharge.
Yeah,
Okay, that's pretty good.
Really?
Better than my iPhone.
Yes, yeah.
it's better than my iPhone. I was in Yaoundé, and they had 3 to 4 blackouts a day while I was operating the systems for the clinical trials. So I'm comparing blackout results versus non-blackout results, manual pipetting mixing versus mixing with a vortex mixer. And I'm doing all these comparisons on the results to see how it affected the CVs, what happened. And the UPSs that we put on these are very rugged. And this is hereditary from when we had the guavas, okay? Because I'm very knowledgeable about African electricity, and even in the bigger cities, it has troubles. Particularly the closer you are to the equator, the more you're going to get thunder and lightning storms, which really affect everybody's electricity. I stayed at a nice hotel. It was a Hilton, and even on my day off, we lost electricity in the Hilton 5 times. So the first time I was there, everybody was doing the World Cup qualifications, and so there was a lot of angry people when the TV went out. And Cameroon made it.
And who do we think is bearing the per test costs if we were rolling this out somewhere? Is that?
Well, at the moment, we are in the phase of we're watching the pipeline. We're looking at potential technologies for evaluations in our country programs. following the evaluation, we're also looking at potential registration within countries, and then we're going to pilot implementation. The pilots will lead us into scale up. Right now we have money from Unitaid to do that, but we're also working, and Divya is the manager on this project. We're also working to make sure that what we do in the field with any of the products, we're also doing the knowledge management that will be required for us to make sure that the Global Fund, PEP Fund, others can have interest in buying the machines. I was interested in knowing who you're working with in Cameroon, because they have a very strong CDC presence and they're interested in point of care.
Well, the gentleman in charge of lab services for the CDC happens to be president of the ASLM. And I'm meeting him for the first time at the ASLM meeting in December. It's the first time that Millipore will be at that meeting.
Oh, wow.
And I joined the ASLM last week. So we're going to do two meetings simultaneously. We'll be at the Nairobi immunology meeting, and we'll be at ASLM. So should be a nice kickoff for Africa in December.
So the way this looks, I mean, from the way I'm reading it, even from the ASLM, this is Africa, the Africa Society for Lab Medicine, is that just like we've done with treatment access, we haven't had the equivalent for lab that would allow us to apply a public health approach. And treatment access will be needed for the longest time. And so all of a sudden the world has woken up to the fact that we need something more than the centralized, regionalized labs.
Right.
So the POC is becoming very popular. The issue now for us is to see how we match all these products, what's really needed in the field. So the throughput of the machine is important. The battery life is very important.
There's one other way we can help you too, because it's not just CD4 that you're doing in this. You do all sorts of laboratory testing. I don't know if you know Millipore or not, but Millipore started as the world's market leader in lab water, and we make excellent small water purification systems. And so if that pops up as a need, please give me a call, because I have water representation in place and water service in place all throughout Africa.
Is that the Boston? Is Millipore's in Bedford?
Yes.
Yeah.
Okay.
I used to live in Bedford.
So the answer to your question is that as long as there's financing for AIDS programs, I think that this has potential. I mean, these point of care machines have potential, especially for the adult population, because we still need CD4 at initiation, but also for managing patients.
Managing patients. And
But even at $2 a test, we're still talking about it. We're still talking about it being free to the client.
And I think
So-
from it, on the one hand, is the $2 per test, but we're also trying to take this more holistic approach of understanding what it means systematically, because
well, that's
there'll
why.
also be the accessibility, there'll be the healthcare resources, the quality management system. But there's also the hope, well, this is a very low cost, low price that you're offering, but there's a hope that with increased demand, the volumes will drive price reductions.
No, I promise you, if I sell a lot of these, that you'll see other. And our whole thing is we have two goals at Merck Millipore. One is to concentrate our efforts in developing countries. We really feel like the U.S. and Europe are well taken care of already.
Yeah.
And then the second thing is we want to keep it on small portable devices. That's we feel is our niche.
Excellent.
Even that portability is going to. I mean, you're not going to walk around with this thing, right?
It's going to come with a carrying case, and it'll have a sleeve for the instrument and a sleeve for the battery. I've been looking at colors. I read in a marketing survey that
So,
the average laboratorian is a woman. She's 42 years old, and her favorite color is purple, or any shade thereof. So,
You're gonna practice it?
Well, there's a lot of discussion around, to accelerate treatment even further. We're going to have to look at other ways in getting more people testing. So I think that especially for the adult population, we are at a stage where there will be more home-based and door-to-door campaign type testing approaches. And I know that the developers get freaked out when people say we'll take the machine on a bike to wherever the testing is going to be. I know some people are a little worried about that. But I think with time and, once we've tried out this machine in a clinic type setting, I think that preparing for the worst in terms of where your machine will end up might be a
I'm
good thing
amazed.
to do.
I did a sale 5 years ago to NASA, and if you go into the space station, there's 2 PCAs running. And the reason we got the flow group to go up into the space lab was the fact that we passed the shake test for takeoffs. And I have pictures of astronauts training in zero gravity with the system that was the precursor to this. So it's
It bounces around the back of my car all the time. In this little box right there. I dropped it on York Avenue accidentally off a car. And it's
Still working.
she's been on in potholes in every 5 borough.
I think we're concerned about dust and humidity in the rainy season, if you're thinking about.
Okay, well, Cameroon, I tested in the lab. We went from 69% up to 90% humidity, and we didn't have any air conditioning, and it ran pretty well. So that's pretty much the acid test I can give you for humidity. The predecessor is in one of them is in the NASA lab that's in Antarctica, and so we feel like we can do the cold temperatures pretty well too.
Have you done head-to-head tests with this and PCR?
That's going to happen when I come out with the viral load. I don't see any other way of getting around it.
Yeah. Could a machine like this, if PCR continues to be this step, are there one could do? We did this a million years ago before the DBS technology came out, where pediatricians were just running CD4 on a child and PCR was not diagnosis. Curious whether that's part of the long-term thinking of this.
Yeah, I think long term it's going to be viral load, and you'll end up with a non-PCR viral load method that'll be demonstrably cheaper.
Yeah, I'm talking about using the CD4% to diagnose HIV infection and things.
To diagnose the infection, I think no, maybe to monitor T cell, yes, but the CD4 percentage alone will never be a diagnostic test.
I know where she's going with this. You could have this machine sitting in some rural clinic with no access to PCR, and there's a child that's falling on top of themselves with potential HIV disease.
Well, you're a pediatrician. You picture yourself with that clinic, and you see the ability to look and see if they're recovering at very low counts, and you see this ability to do cytopenias. That's gonna be a challenge. And I'm gonna have a huge debate with our own internal regulatory group. Where do I put the threshold on calling the low end linearity? I know at 50 cells, where I think I'll call it, really below 50 is not going to make a difference to anybody on how they treat the patient. But if I'm accurate down to 50, then yes, you'll be calling recovery at earlier levels.
Well, my point is that you can anticipate that clinicians would know that with only this in the clinic are going to use it in a variety of ways you haven't imagined and don't have
Well, I would hope.
Regulatory authority, but you might just run this comparison and do your own knowledge because in the field you're gonna use it in that way. So
I've been in hematology for 30 years, okay? And,
We'll figure it out.
yeah, they'll figure it out, but I'll tell you, the pathologist will want to make a slide at that point anyway. And the slide will validate whatever you see on the instrument. I did a lot of slide reviews when I was in Cameroon, just because I wanted to see what was going on. And
Basically, what she's saying is, could we marry this to an antibody test, which we know only tells you that the child is exposed to
giving John a good idea here.
plus-
This is the guy that needs to hear that.
We're trying to get the viral load. I mean, we've got a lot
Yeah.
of good ideas to do the viral load on flow, but it will certainly be virus detection at some level.
Yeah.
I mean, in the worst case.
Well, and that's my hope is, we can diagnose 1 and 2 and give them an idea of,
Another reagent for just a simple diagnostic
yeah.
for those.
Sounds good.
one blood sample is
Absolutely. Why not?
I mean, this is wonderful because the CD4 percentage is riding on the CD4. So people, countries will be fascinated by this because you can do both and children can benefit. But even
Yes.
for the viral load, we need that qualitative test for the child. So if you can do a combo like this, I don't know how easy it is.
Well, the hope is a single system that might be 3 tests. You might run the sample 3 times, but you would get the viral load, the CD4 percentage, and or whatever. The one I think that we'll probably do first is malaria. Because my financial justification to the company is 40% of the AIDS patients have malaria.
Okay, so thank you.
Hey, thank you for having us. I just wanted this to be
Where are you all from? Are you
the
from-
genesis
from the US
of
or-
a good relation. We're all from the